Welcome. Thank you so much for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Today's session is part of our Mass General for Children Parenting Series, a special collaboration between the Blum Center and Mass General for Children. Before we get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has been muted so that we hear our panelists today. If you have any questions for our panelists, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff, our co-host, and panelists will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. All right, so next I'm going to turn it over to Brianna Beckfold. She is the project manager and editor for Mass General for Children, and she will introduce you all to today's panelists.
All right, thank you, Amy. So everyone, welcome to this session of the MGFC Parenting Series at Mass General for Children, where pediatric health experts share their knowledge on various pediatric health and family-related topics. This year, we're collaborating with the Blum Patient and Family Learning Center at Mass General, and today our session is going to focus on RSV, or Respiratory Syncytial virus in children. We have 5 speakers with us today, the first of which, excuse me, my computer delayed there. The first of which is Dr. Vandana Madhavan. She is the Clinical Director of Pediatric Infectious Disease and Immunodeficiencies at Mass General for Children. And she's also an attending physician in the Pediatric Infectious Disease and Pediatric Primary Care programs. She's also the Director of the Advanced Pediatric Clerkship and Pediatric Clinical Capstone at Mass General for Children and Harvard Medical School. She earned her medical degree from the University of Virginia School of Medicine and her master's in public health from the Harvard T.H. Chan School of Public Health. She then completed her residency here at Mass General for Children and did fellowships in pediatric infectious disease and health services research at Boston Children's Hospital and Harvard. Our next speaker is Alexi Arauz-Boudreau. She is the Associate Chief of Pediatrics for Primary Care, the Mass General for Children Medical Director for the Mass General Hospital and Mass General Physicians Organization Medicaid ACE, and the pediatrician for Mass General Chelsea Healthcare Center. She earned her medical degree from Harvard Medical School and her master's in public health from the Harvard T.H. Chan School of Public Health. She completed her residency here at Mass General for Children and Mass General, as well as the Harvard Pediatric Health Services Research Fellowship and the Morgan Commonwealth Fund Harvard University Fellowship in Minority Health Policy. Our third speaker is Dr. Phoebe Yeager. She is the Chief of Pediatric Critical Care Medicine and the Pediatric Intensive Care Unit here at Mass General for Children. She's also the Program Director of Pediatric Critical Care Medicine Fellowship Program. She earned her medical degree from the Geisel School of Medicine at Dartmouth College and completed her residency here at Mass General for Children and Mass General Hospital. She also completed a fellowship in general pediatrics and pediatric critical care medicine at Boston Children's Hospital. And from here, I'll hand it over to Amy briefly to introduce our last 2 speakers.
Thank you. Joining us today, our fourth speaker, we also have Lori Pugsley. Lori is the Nurse Director for Inpatient Pediatrics at Mass General for Children. She earned her undergraduate degree in nursing, master's in education from the University of Massachusetts, and a doctorate degree from the MG Institute of Health Professions. Lastly, joining us, our 5th speaker, we have Kimberly Whalen. Kim is the Nurse Director of the Pediatric Intensive Care Unit at Mass General for Children. She is also the lead nurse planner for Harvard Medical School. She earned her Bachelor of Science degree in nursing from the University of Massachusetts and Master's in Nursing Informatics. So next, I am going to hand it back over to Brianna, who will start today's session with a series of questions for our speakers.
Great, thank you so much. All right, so our first question, like I said, I will hand this over to whoever would like to answer. perhaps Vandana for the first one. What is RSV and how do children get it?
So I can start. So RSV, like Brianna mentioned, stands for Respiratory Syncytial virus. It's one of the many, many respiratory viruses that circulate at different times of the year. And I'll sort of jump ahead to something that we'll likely come back to as well. Typically, it's a late fall, winter, early spring virus, but the COVID-19 pandemic has not just disrupted all of our lives and schooling and work, but it's disrupted viruses in terms of their seasonality and the times of year that we typically see them. And so this year it's been different. And so we've been seeing RSV start early in the year and have more cases as well. And we'll talk about that a little bit more later as well. It's a virus that in older children and adults can be one of the many viruses that just causes a cold or an upper respiratory infection, something, we would typically think of like a runny nose, a stuffy nose, or congestion, a cough, where people, are sick, but they're generally not, sick enough to, need additional support. But in younger children, especially, those under the age, of 2 or 3, and those with underlying lung disease, especially from being born too early, being really premature, those with congenital heart disease, structural heart disease, they can have more complications where it's not just a cold or an upper respiratory infection, but the virus can go into the lungs and cause a lower tract infection, specifically inflammation of the bronchioles, which are smaller airways in the lungs. And with that inflammation, if you think about, the airways in a young child, are just so much smaller. Like if the, this is kind of thinking back to geometry, but thinking that, if you say it's, the radius or the diameter is only half as small, the actual area, if you think about like inflammation decreasing the diameter of an airway, the actual area, the surface area that's available for breathing, for air to go through is even more affected in the little ones. And so that's why that lower respiratory tract inflammation in those small airways causes so much more damage and causes more significant inflammation and infection in the little ones, especially those with higher risk factors. And when it does get into the lower respiratory tract, and cause bronchiolitis. Again, most kids are fine and they're still able to be taken care of at home, but some of them will need additional care.
Great, thank you so much, Vandana. Our next question is, how does RSV differ from other respiratory illnesses?
Take that one as well.
Yep.
I'll do that. So I kind of hinted that it's like one of the many viruses that can cause, cause colds. A lot of other viruses can, in little ones, cause a lower tract or bronchiolitis in infection, but RSV is the most common cause of bronchiolitis in infants and young toddlers. And so RSV, just in terms of sheer numbers in a regular season, causes more, more disease, and therefore, causes more children to get sick, and therefore, more children to need additional support, need to be hospitalized, and need additional care.
Okay, thank you. Our next question is, how does RSV affect babies and children of different ages? I know you touched on that a bit, but if you could expand on it, that'd be great.
Yeah, so I can expand a little bit. So like I said, it's the younger children that we worry about the most. I should comment that like a lot of respiratory viruses, COVID being a huge exception, which made it very different. We typically talk about a U-shaped curve, and I realize I don't have slides. I'm using my hands a lot to gesture, but we worry about the very young and the very old. And so RSV certainly can cause more complications in older adults, especially those with compromised immune systems, those who've had transplants or on medications that suppress the immune system. But we worry about the other extreme. We all take care of children. And so it's the youngest children that their airways are the smallest. They're going to be most affected by, by that inflammation caused by the virus, and therefore are be more likely to have complications. And by complications, thinking about the inflammation in the lungs, the difficulty breathing. Usually, supportive care is fine, but sometimes infants and young children with severe bronchiolitis, their oxygen level might drop. So they might need to come into the hospital to get supplemental oxygen. Sometimes they can even, stop breathing, need additional support. And so it's not just oxygen being given, through blow-by or through like a cannula in the nose, but they actually need to be getting more respiratory support, being on a machine like a ventilator, to need additional support. Maybe Dr. Yeager can talk a little bit more about what that means as well. Sometimes they need IV fluids because they're breathing faster, breathing harder. It's more difficult, for babies and young children to eat and to drink normally, keep themselves hydrated. They're also losing more fluids because they're breathing faster and losing more fluids from their lungs. And so sometimes babies need to come in, not necessarily for the breathing problems, but because they're dehydrated. And so those are some of the complications that we see in the youngest children. But maybe Dr. Yeager can expand on that a little bit more and talk about what most severe RSV can look like.
Before we jump to most severe, can I add a little bit about I think the part of the question was, what are the differences in the symptoms for the younger kids to the older children? For children less than 6 months or 6 months, less than 5 years, the younger children will have more of a whistling sound when they're sick at home. They'll be a little bit more of a wheeze, where an older child, maybe over 5, would have more of a cough or a bark a little bit more. The infants and the younger children will also breathe, and you'll see their nose flare a little bit, or you'll see their chest pull in and out, or around their necks pull in and out. Where the older child, you may not see that as much. The younger children often will eat until they can't, meaning they're going to have a hard time breathing and eating at the same time. And the older children usually can eat a little bit more for a little bit longer. So usually when you're seeing your infants or your young children, they'll have slightly different symptoms than an older child will have. And the activity is when they're lethargic or tired and not doing as much, and not interacting and socializing, engaging you in your the play and the face interactions is usually also another sign in the younger children, where they'll disengage a little bit more.
Excellent.
Do you want to add any more?
Yeah, I would just continue to build on some of the themes that you've put out there. I do think the number one complication is dehydration. You have young infants who are using all of their energy to breathe, which leads to increased fluid losses through breathing, through fevers, and then an inability to keep up with that because it's just too much to be able to eat and breathe at the same time. And so I think, all of our therapies, and you'll hear this theme throughout this conversation, are all about supportive care. We unfortunately don't have a magic bullet to treat RSV. And instead what we do, and the theme is, we support infants and children as their own body fights off this virus. And so for the dehydration that develops, we may end up placing an IV to give IV fluid directly into the vessels. Another thing that we may do is pass a soft little feeding tube through the nose with the tip that goes into the stomach, so that we can continue to give good nutrition to babies so they have that good energy they need to fight the virus, but be able to bypass the effort it would take them to actually take fluids and nutrition in. Another complication that Dr. Madhavan alluded to was the development of a real oxygen requirement. And so sometimes it's just a matter of applying a soft little nasal cannula to increase the concentration of oxygen and the gas that an infant is breathing. And sometimes, though, it requires a little bit more support for babies and toddlers who are using so much energy to breathe that they become fatigued and tired. And when that happens, they may then have ineffective breathing to support the body. And we can apply a different type of soft nasal cannula that actually helps them get the air in and helps to offload the work that they're having to do so that they can rest and recover. And I would say that I'm now talking about some of the sicker patients. The vast majority of infants and children who get RSV can be managed at home. And so you're talking to an intensivist. So I'm telling you sort of what the more extreme end of this looks like. And at the most extreme end, which we very, very rarely see, are children who actually need to have a breathing tube put in for a period of time to really take over and support breathing while they get better. The children who end up in this situation tend to have underlying problems that put them at really much higher risk for getting severely ill. And Dr. Madhavan already talked a little bit about babies who were born very prematurely, or children who have underlying heart or lung problems. And then the last piece that I wanted to add to this is that children who have underlying reactive airways disease or asthma, they may end up getting a little sicker than somebody who doesn't have asthma. And so in that case, it may be a cold plus the need for increased use of an inhaler, or maybe a short course of steroids. That would be a decision made with your pediatrician. And again, we see the extreme cases where we need kids to be getting more of those therapies that require hospitalization. So again, just to put this all within the greater context, most kids can be managed at home. A very small subset need the help that can be done in the hospital, and a very, very tiny subset of those children end up requiring, an ICU level care.
And Phoebe, I would add that the majority of children who are treated at home, the things that you can do, right? Now, the course might be 1 or 2 weeks long. I mean, they may have a virus this cold for a period of time. And always talk with your provider, your pediatrician, always do that. But typically they'll suggest Motrin or Tylenol. You want to keep the fluids going as much as possible to keep them hydrated and keep those secretions loose. You could go into the bathroom in the shower and keep moisture going for these children. That really helps a bit. We typically do not give antibiotics for this. They're not needed. It's a virus. And so really it's that supportive care that Phoebe was mentioning that is needed prior to anything. And most children do fine.
And I just want to build on a couple of things that people mentioned in terms of what Lori was talking about in terms of supportive care. Really want to emphasize this is a virus. Antibiotics, which treat bacterial infections, do not work. RSV is not typically an infection that causes someone to be more likely to get a bacterial pneumonia or anything on top of that. That would be a much more unusual situation. So it's not typically that you go in, to the doctor's office, get instructions about supportive care, and also get an antibiotic. And so there will be discussions about the humidifier in the room, the shower steam. For children who are 1 and over, honey can work really well if the cough is keeping them up at night. Honey is a great cough suppressant. We don't recommend over-the-counter cough and cold medicines for young children. In primary care, I typically say at least age 6, and even then I talk about honey more than I do, sort of generic and brand name cough and cold medications, because we really just want time to do its job. There's no specific antibiotic, antiviral that treats RSV. It's really about helping a child be comfortable enough that they're keeping themselves hydrated, that they're, watching out for those signs of increased work of breathing that people have talked about, and knowing when to think about a call to your pediatrician, when to think about, actually bringing your child into the emergency room. But the vast majority of children will be fine with likely just a phone call, and a lot of pediatricians' offices are still doing a lot of virtual visits. And so that might be great. With a virtual visit, I can see if there's that nostril flaring, if there's that tugging. I can hear, how a child's breathing. I can do a lot of that and say, great, let's keep doing the supportive care. And that way you save a visit to the pediatrician's office where you might get exposed to other viruses. And so we're really trying to keep visits to pediatricians' offices, urgent care centers, emergency rooms for, children who really need that. And that's going to be a very small percentage of care. Dr. Yeager, you might have, more recent numbers. I know our more recent numbers looking at the numbers of positive cases within our system, about 10% of those patients were actually requiring hospitalization. And that's about, within the range of what we typically need. And remembering that not everyone who has RSV gets tested. So there's a larger pool of children, especially older ones who don't have risk factors, who likely have RSV, but who don't even come in for testing because it's not going to change their management. The recommendations for supportive care will be the same.
Great. Thank you so much. I think it would be helpful to define what is supportive care versus what is a treatment or a cure, and how each would apply in the case of a child who has RSV. So maybe Lori or Phoebe.
I think a lot of what we're saying is RSV is supportive care. And we can talk a little bit about a small cohort of population of patients that can get preventative medicine very rarely, and I'll let one of the other providers speak to that. But our supportive care,
we can address that later.
Yeah, we've been talking about, which is fluids, maintaining that temperature. So if you can keep that temperature down, children breathe better, believe it or not, and they're not losing so much of that fluids through the high temperature that they may have, and rest. Those are the three big things. As it moves past the vast majority of patients, which is care at home, then the supportive care moves to what Dr. Yeager was speaking to, which is what else can we do for supportive, for IV fluids, for temperature, and or to support their breathing.
Great. Thank you so much, Lori, and everyone who addressed various questions there. Our next question is, how long does RSV typically last in children?
It's about 1 to 2 weeks.
1 to 2 weeks. Okay. All right. And then our next question is, when should a family member be concerned about their children's symptoms? What should be the tip off that they should maybe call the doctor?
I can take that if you want.
Sure.
First thing is your child's skin color. If there's any blue or concern about skin color, call 911. That's your first thing. If there's an emergency, you want to be able to, or if they're trouble breathing, that they're not breathing, you want to make sure you do that. But if your child has been sick for a few days and not improving, it's probably a good idea to touch base with your provider and do a virtual visit if you can, or to find out, they can ask more questions about you, your child's history, and how things have been going. Difficulty breathing is always a reason to call your provider. Usually children under 1, in any of those cases, we ask you to call. If they're not active and they're not interacting as much, if they have a high fever, and if they're not having wet diapers because they're not drinking, those are usually pretty good signs to call your pediatrician. I'll let others chime in if there's others.
Vandana, is there anything on the outpatient side that you can think of?
No, I think that's great. And I think the only other thing is that if your child is, I know we'll talk about this a little bit more specifically about preventative, measures, but if your child qualifies, you'll already be getting, your family will also already be getting the counseling of, what RSV looks like, what are concerning signs. I will say that even if your child doesn't meet criteria for getting Synagis, which is the preventative, antibody, if there are underlying risk factors, hopefully that's already been part of counseling. But if you're wondering, like, oh, my child has this condition, is this something I need to worry about? A call to your pediatrician's office is a great thing to say, like, is there anything different that I need to be looking out for? Or should I have a lower threshold? So kind of knowing, where your child, fits in that as well. I'll also say that we have updated materials for patients and families about RSV. And so maybe someone can put in links into the chat, although I don't know if can attendees see that, but we have links, and so that can be shared with people as well.
Great, thanks, Vandana. And I know you just touched on this very briefly, but the next question is there a vaccine for RSV?
So right now, there's no vaccine that's actually available that's preventative, but there are a lot of different vaccine candidates. You might have been reading about it in the media. There's been a lot of attention because of this RSV surge, because we're seeing so many more cases. And in 2022, the one that seems to be most the closest to potentially getting, approved is not a vaccine directly given to children, but a vaccine given to women, to people during pregnancy, with the idea that during pregnancy develop antibodies, and then later in pregnancy, those are transmitted through the placenta to the baby. And so the baby has them for the first, typically 6+ months of life. So when the baby's youngest is at, greatest risk for RSV complications based on age, they have antibodies, from the pregnancy that don't last, forever, but that they, that are there, helping potentially decrease the burden of RSV, decrease the risk for complications. So that's the one that's going to be closest, most likely, to being available. Remembering that even when it's approved and clinically available, it's for people next year. So babies in 2023-24 in that season would be the ones who are protected. There are also vaccines that are being looked at to give to older adults who are at risk, and also ones to give to children. But right now, that's the only vaccine. And then, since I mentioned it, I'm just going to pack it in. So what we do have is not a vaccine. Remembering, a vaccine is where your body develops its own immune response to either like a low, concentration of the virus itself, or a component of the virus, and develops longer term, protection on its own. So when the body sees it, sees the actual virus or, actual, pathogen, it knows how to respond. I view it as sort of vaccines are like the dress rehearsal or the practice, so that when you get to the big show or the big game, your body knows what to do. What we do have for RSV is not a vaccine, but it's the antibody. It's an antibody itself against RSV, called Synagis. Palivizumab is the generic name, and that's given once a month during RSV season, which is typically 5 months, but it can be longer in unusual seasons. But it's not given to everyone. It's not given to all, young babies. It's given to those at highest risk. So those who are born very prematurely, before 28 weeks, who have underlying significant lung disease or, heart disease. And so it's really to protect the highest risk children who are at the greatest risk for needing to come into the hospital, needing the sort of higher levels of care that we've talked about. But it's very important that even though it's a shot, and it's like, yes, it's an injection, it's not a vaccine, it's just antibody that's given short-term protection. And because that's cleared by the body, it's given every month during the RSV season.
Great. Thank you, Vandana.
Thank you so much. You will see that we opened up the chat. So if you have any questions for our panelists, feel free to enter them in chat. We'll hold them off and ask at the end of the session. So I'm going to take it over here and ask some questions. You had provided some great home care tips for children who are not feeling well with RSV at home. Is there anything else you'd like to add to that?
I would say probably how it's spread in the home, right? So it's a cold. It appears like a cold. It looks like a cold. So blowing the nose or sneezing, which may be an adult who has a cold that might actually have RSV and just present like that. And then touching surfaces. So when you think about it, it's the same thing we'd ask you to do for any cold. Cover yourself when you're sneezing. If you do the tissue, throw it away, wash your hands, good hand hygiene. And then any surfaces that are what we call high touch, things that you touch all the time, doorknobs, bathroom faucets, handles, any of those, just keep cleaning those periodically throughout the house, any of those types of services. surfaces, excuse me, is how it's spread. So you just want to be wary of that. There's a lot of love we give our children, right? And we want to keep giving our children, but when it's cold season, sometimes we give them a little bit more than the love. So try to, not always kiss when you're not feeling good, or keep your distance when you're not feeling good, for other children around you. And then crowded places. There's good times to be together with family, and there's times that maybe it's okay to spend a little bit time apart. By no means do you need to isolate completely, but you should just be wary of your environment and who's around, and how close you are with each other.
One thing that I want to add to all of that great advice is that I tell my own patients, like, make me the bad guy. Tell them that your doctor told you to ask questions. And so parents should really feel empowered to ask, especially, Thanksgiving is, behind us, winter holidays are ahead of us. There's going to be more gatherings, and we want to prioritize, time with, family and friends, but asking if you have a little one, especially who is going to be, at higher risk for complications from RSV or influenza or, other respiratory viruses. I know the focus is on RSV, but I just want to, think about the numbers of influenza cases, the number is rising as well. And so asking family members, has anyone been sick? Are you getting over anything? Being, empowering them and saying, what, maybe we'll come the next day. Maybe we'll come, maybe, we'll do, reschedule, and asking to protect your child rather than sort of getting somewhere and realizing that there are multiple, sick adults who might just have a cold, might just have those upper respiratory symptoms, but that could be much more damaging, to your little one. And so asking those questions and just putting in a plug that we talked about how there's not a vaccine for RSV, there's not, preventative measures for everyone, but that influenza vaccine is available to everyone 6 months and over who doesn't have a true allergy, a true medical contraindications. Is available for 6 months and up. Get everyone, vaccinated. COVID vaccine is available for everyone 6 months and up. Making sure that, everyone who is eligible, so all, older siblings, adults in the family, and again, parents should feel empowered to ask, other family members before getting together. That's always part of my question. Ask, who's going to be around your child? Have they been vaccinated against flu, pertussis, or whooping cough is another important one to remember. Just making sure all the vaccines that the littlest ones can't get protected, you're cocooning and getting all their grown-ups adequately protected as well.
Thank you. Is it possible for a child to get RSV more than once?
I see Lori shaking her head.
You want to take that
Yeah, Lori, go ahead.
I was going to say, yeah, it is. Yeah. That's the reality. Is just like adults, they are able to get it again.
How about, go ahead, do you have something to add?
I was just noting that as they get older, they're less likely to have complications. So it's not going to be as bad. A 6-month-old is not going to be as sick as, a 5-year-old, with RSV, but it is absolutely possible to get it more than once.
Thank you. How about getting RSV along with other illnesses? Is that possible?
Yeah, we're actually seeing quite a bit of that. At home, you wouldn't know, right? It would just look like a cold. You may not know what they have, and we often don't test for RSV. But when we have them in here, we have the ability to test in the hospital, and part of that is for placement and knowing where to place the patient. But we're seeing a lot of multiple germs at once in some of our children, which isn't uncommon. It's just that we're able to test for it so we can see it.
And I would just add to what Lori said about testing. Really, one of the only reasons that we do testing when kids come into the hospital is to allow us to figure out the best placement of patients so that they're not at risk of passing along different germs to one another. There's really zero reason to be testing in the outpatient setting to know which virus your child has, because it does not change the therapy. And the theme of this hour has really been supportive care. And whether it's RSV or one of the other viruses like, rhinovirus or one of the other ones, it's all about hydration and fever control and rest and time.
Yeah, and I will say that if really want to, think, we've talked a lot about like what are concerning signs to warrant bringing your child in for an in-person evaluation, those signs of dehydration, those signs of increased work of breathing, but coming in just for RSV testing, if your child doesn't have those concerning signs, isn't going to change anything and is, like I mentioned before, is potentially exposing your child and your family to other viruses, like during the time spent in the waiting room, spent, traveling, to the doctor's office. And so, coming in just for a test isn't going to change anything. So really want to encourage you, like so much of this care can be done at home. So unless you're seeing those concerning signs, a call, a virtual visit, if you have more questions is great, but coming in just for testing might cause more issues in the future.
Thank you. What do you predict the rest of the fall and winter will look like with RSV?
Oh, that's a tough one. I think it's so different this year that we're unsure. There's an old saying that used to be RSV used to go from turkey to tulips, right? From Thanksgiving right to the spring. That's when it started and that's where the peak was. And this year we saw it really peak back in October. And so is the trajectory the same? We don't know. And we're guessing it's going to the peak is going to come down, and yet it's still going to linger right until the spring like it typically does. And so we'll just kind of watch and waiting. But we do think that the peak we're watching the peak come down. So hopefully, the RSV intense part is slowing down a little bit, but it will be here till the spring.
And I think although we think and hope that we have seen the peak and it's behind us, that peak was so much higher than in past years that even if the numbers are declining, we are still, upwards of over 200% more volume of children with testing positive for RSV than we were last year or the year before. So the numbers are still strikingly high. And we don't know whether there will be another peak later. We often see increased numbers after big holidays and gatherings because RSV, as well as other respiratory viruses, are so contagious. The other trend that we have been watching, and Dr. Madhavan alluded to this earlier, is influenza. And we are starting to see those numbers increase. That's just something that we're watching very closely. And I think that it is worth saying 2, 3, 4 times that the flu vaccine is available for children 6 months of age and older. And when we ask ourselves, like, what can we do? In addition to all the things that Lori said about washing high touch surfaces and being careful to contain sneezes and coughs, something that we can all do is we can get ourselves and our children vaccinated against influenza as well as COVID for those 6 months of age and older.
Thank you. That's like a message that I always like people to repeat as many times as possible. I just wanted to add, going back to like the RSV numbers, just to put it into a little bit of context, when we start seeing the percentage of tests that are performed be positive at greater than like about 4 to 5% for RSV, we think about like, oh, RSV is really circulating. We need to think about this. I looked at the Massachusetts numbers just this morning, and the last couple of weeks, it's been about 20% of tests that have been performed have been positive. And so I think it's like even like 22% or so in like the last week. And so just to put into context, we're really seeing, just the sheer numbers are high. So even if we say, oh, look, we're seeing the numbers go down and it's 50% less, that's still 10%, which is still twice the number of, of percent positivity that we would typically call like an RSV season. So it's really hard to predict how things are going to look.
Thank you. How has RSV affected Mass General for Children, and what is Mass General for Children doing to manage it?
Oh, that's a good question. I would say that this team right here has been extremely collaborative in making sure that we can care for your child if you come in or if you need to be admitted. We have resources available in all different areas, and we are able to have you, if you're coming through your doctor's office, straight to the floor if it need be, or if you're coming through the emergency room, we have the skill sets to be able to treat you where you're at. And support you, and then identify a best area for you to go. I'll let the others chime in.
Yeah, I would just say, we learned a lot from the experience of having to deal with a surge of patients needing hospitalization during the COVID pandemic. And I think that experience has really informed our response to the current surge of children needing an increased level of care around RSV and other viruses. And so, we are really collaborating across not only Mass General for Children, but with support from the entire hospital of Mass General, as well as the entire system of Mass General Brigham. And then even beyond that to the whole New England region, where we are having weekly meetings with our nurse and physician colleagues across the different hospitals in New England to talk about the numbers and to talk about our capacity challenges and to support one another to ensure that every infant, every child who needs to come into the hospital gets to the bed and the right bed that they need to get the right level of care that they need.
Thank you. Some may have heard that there are no beds available for children with RSV. Is there a plan to address this issue?
I mean, I think, as I was just saying, that there's been tremendous collaboration across the pediatric intensive care units, across the pediatric wards, across emergency departments, not only in the Boston area, but Massachusetts and the greater New England area, to ensure that we can find the right bed when we need it for any and every child who needs a higher level of care. And I think that our ability to do that has been very successful.
Thank you. We have a question from the audience. At what temperature does it generally make sense to medicate a child with fever reducer versus allowing the immune response to help fight the infection?
Oh, this is a good one. I think you may get different people with, you may have an aunt, an uncle, a grandparent with an opinion. You may have one provider versus another provider with a different opinion. I think when you're at home, if your child is looking okay and tolerating things okay, it may not need meds. That's pretty much the rule of thumb. If the fever gets to a point where they're lethargic, meaning tired, not interacting, not eating, you probably should be treating it. That is not a number, but I would say is how the patient is reacting, how your child, your child best. And I would say tune into what their needs are and then manage accordingly. But I'll let others chime in.
Yeah, I would echo that too. I do a lot of talk about like fever isn't the disease. It's a sign that your body is doing what it's supposed to. And it's the normal, inflammatory response. And so it's a sign that your child's immune system is functioning and working to fight something. And so one child might be, 100.4 as a rectal temperature is a true fever. And a younger child might not be drinking as well at 100.4, might need Tylenol at that age to help a little bit. Other children might have 102 fever and be fine and be playful. And so the fever itself isn't what you need to treat in an otherwise, healthy child. I will say there are going to be, certain, if there's an underlying risk factor, your child, say a child with an underlying seizure disorder, for example, where the fever might increase the risk of seizures, there might be counseling that, your family might have received about managing fevers more closely. And there are a lot of other examples like that. So if you've received specific instructions about treating fevers early, reducing the risk of seizures or metabolic concerns, for other reasons, yes. But if your child is otherwise healthy, has a fever in the setting of a routine viral infection, treat your child, not the number on the thermometer.
Thank you. If a parent is going to treat their child's temperature with the fever-reducing medications, what are your thoughts on the various medications, for example, Tylenol versus Motrin, or is it safe to give them both at the same time? What are your thoughts?
And I'll jump in there first. I mean, I obviously in primary care, I do a lot of counseling about this as well, and as well as a PDID doc. It's absolutely okay to give both. They work in different ways. Some children are going to feel, are going to have more of a response to one or the other. Remembering that both Tylenol and Motrin, or I say acetaminophen and ibuprofen, they both work to bring down fever. They both work to help pain. Ibuprofen is also an anti-inflammatory. Ibuprofen also can irritate the stomach a little bit more. So if your child isn't eating as much, it has a fever, but has had an empty stomach, hasn't been eating much, Tylenol might be a little bit better tolerated for that reason. But there are other reasons why ibuprofen or acetaminophen might not be indicated based on underlying medical conditions. That's another great thing to ask your child's pediatrician and any other, subspecialists. Is there any reason that we should avoid one or the other? But typically, whatever works for your child, knowing that they both help with fever, they both help with pain, and ibuprofen is an anti-inflammatory as well.
Thank you. You had mentioned earlier on that there are some handouts available on RSV. Where can families get more information on it?
Brianna, you want to take that one? You're on mute.
Yep, there we go. Sure. On the Mass General for Children website, there's something called the Pediatric Health Information Library, and that's basically a one-stop shop for all of the patient education material that our providers have created. Everything is very reliable, evidence-based, written by our own experts. And there is information on RSV and tips to prevent RSV under the primary care and infectious disease categories.
Thank you. I'm going to enter that in the chat for anyone's interested. So I think that's all that we have for questions. Before we end today's session, do you have any final thoughts you'd like to share with the audience? All right. Well, thank you so much, everyone, for taking the time to join us today. Hopefully you found today's session helpful. As I had mentioned, today's session is being recorded. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the day.
Yeah.